Now we have the talk of Dr. Valentina Tsibizova. She will talk to us on fetal cardiac diastolic function and perinatal outcome. She is a specialist, medicine specialist in St. Petersburg, Russia. Welcome, Dr. Tsibizova.
Good afternoon, dear colleagues. I will speak about fetal heart diastolic function with different disease. I'll speak about fetal hemodynamics, heart evaluation, congenital heart disease and cardiac function, about fetal intervention and cardiac remodeling, placental role in UGR, and diastolic dysfunction as predictor of perinatal outcomes. As we know, special environment defines the fetus hemodynamics. The oxygenated blood from the placenta directly enters in the left heart through the ductus venosus, providing more highly oxygenated blood to the brain and upper body. The oxygenated blood from the inferior vena cava is delivered to the lower body through the right heart, largely bypassing through the by lungs, bypassing ductus arteriosus because of the great pulmonary vascular resistance. The placental circulation determines right ventricle afterload, and cerebrovascular resistance determines left ventricle afterload, and they automatically stabilize if it's hypoxia of the fetus. For the evaluation diastolic dysfunction, we are using routine evaluation of ductus venosus and the evaluation blood flow in umbilical vein. But also we can use another vessels for evaluation, like a pulmonary vein. We can use different tools of Doppler, like tissue Doppler indexes to check inflow in ventricles, to use a strain for assessing strain of myocardium. But when we evaluate fetal heart function, it is most important to understand who should be checked. For evaluation cardiac function, we are using in evaluation TTTS, cases, TRAP, UGR, and the fetuses with infection like a parvovirus and cytomegalovirus. This is important because their cardiovascular function plays essential role in the prognosis for fetal life. Important to evaluate inflow of ventricles, and we can see that, inflow through the atrioventrical walls has two peaks: early peak of early phase of by passive relaxation, and active phase for atrial contractions. In cases where there is a cardiac overload and hypertrophic myocardium, like in TTTS cases, we will see monophasing flow, which tell us of deterioration cardiac function. But also we can evaluate EA ratio of early phase to active phase, and normally is less than 1 and is increasing in hypoxia and cardiac overload. Tissue Doppler is very useful also instrument, and will tell us about annular displacement of valve, and we can evaluate by this methodology also ratio of E prime and A prime. Normally is increasing with gestational age and depends of developing of cardiomyocytes, because E prime is increasing with cardiomyocytes development. One of the highly recommended echocardiographic parameters for the assessment of diastolic function in adults is E to E prime ratio. However, references for the fetus are limited, Usually, this ratio decreases with gestational ages. The reason of decreasing is because increasing with gestational age maturation of cardiomyocyte and is agreement of velocity of E prime. TAPS and MAPS we can evaluate by M-mode, and we will evaluate longitudinal velocity of annulus displacement, annulus movements. Usually TAPS is higher than MAPS, and this is because is predominant of right ventricle and because of different cardio fiber in different ventricles. Elevated of afterload can be case of tract obstruction. Usually it's aortic stenosis, pulmonary stenosis, ductal constriction, and in cases of TTTAs or fluta, we can see this tract obstruction. As we know, antenatal death in cases with congenital heart disease is very rare. And this is because ventricle is can adapt and redistribute combined cardiac output with remodeling of dominant ventricle. In our cases of different congenital heart disease, we also didn't find any changes in diastolic dysfunction because heart is adapted to this. Aortic stenosis is a good example also of ventricular of increasing, after load, and we can see that ventricle's systolic and diastolic function is changed, and we will find dilatation firstly with a retrograde aortic arch flow and left to right flow across the foraminal valley and monophasic inflow. And aortic stenosis usually is progressing can culminate in hypoplastic syndrome. Ductus arteriosus constriction is also example of afterload increase, and in most commonly is related with non-steroidal anti-inflammatory medication in the late, mid, and the early third trimester. We can see increasing in diastolic velocity, tricuspid regurgitation, which is often seen and can tell us about high right ventricle systolic pressure. Low urinary tract obstruction also is associated with afterload increases, which caused by compression of iliac arteries, renal dysfunction, lead to release vasoactive mediated, and as a result deteriorate diastolic function and heart remodeling. Also, pulmonary hyperplasia altered hemodynamics and to decrease pulmonary flow with lower pulmonary venous return and less left heart healing. Same results have shown by Cohen and the co-authors in 2019. They declare that in all cases was diastolic dysfunction, and in 16% was evolution in hypoplastic left heart syndrome. The heart plays a key role in fetus growth restriction, and in early onset, before 32 weeks, with severe placental insufficiency, we can see a redistribution of cardiac output, resulting in decreased right to left cardiac output and developing ventricular hypertrophy, cardiomegaly, and also we can find a monophasic ventricular inflow. In a late onset, we can find just remodeling of geometry with a decreasing of sphericity index. And with if with early onset, we understand pathophysiology of this process. With late onset is still not established. Myocardium is most likely tissue affected by hypervolemia, and which can lead to cardiomyopathy and diastolic dysfunction with decreased ventricle compliance. This is the case of great peak flow through the aortic and pulmonary valves, which increase cardiac output, which is a result of somatic growth, and the myocardial complex will be changed. In gestational diabetes, we will find increased ratio EA, and E prime to A prime also will be high. In severe tricuspid regurgitation, with cardiomegaly and severe ventricle dysfunction can result in Epstein anomaly, which is related with a 45% of fetal death. And all of these cases should be intervened by a pediatrician cardiologist with to reduce the ductus arteriosus diameter to create antegrade flow through the pulmonary artery. Cardiomyopathy keeps 2.5% of all fetal cardiac disease and can be hypertrophic and non-hypertrophic, but also is related with a high demise intrauterine age and with a low rate of 5 years survival. And we can find also diastolic dysfunction. In these cases, we can find the high myocardial performance index and prolonged isovolumic relaxation time and very low combined cardiac output. And what we should conclude that for the diastolic parameters like isovolumic relaxation time prolonged with a monophasic flow through atrioventricular valves and absent wave in or reversed wave in ductus venosus can tell us about diastolic dysfunction. And increased EA ratio will show us about volume loading and or external compression. Diastolic function is very for a K parameter to evaluate fetal cardiac performance in utero in severe conditions and K predictor for fetal neonatal outcome. Moreover, it precedes systolic dysfunction. Thank you so much for your attention.
Thank you, Dr.
Thank you.
Tsibizova. Any questions? Thank you very much.